Yeah, so again, good evening, everyone, and welcome to the today's webinar on pediatric gait issues, prevention and rehabilitation. So thank you so much for taking your time and joining us today here. We'll be discussing about the gait developments in children, the common gait abnormalities seen in pediatric practices, when these conditions require medical attention and the rehabilitation approaches that can help children achieve better mobility and a good quality of life. Whether you are a physiotherapist, pediatrician, healthcare professional, or a parent, I hope today's session will provide you a lot of practical insights that you can apply in daily life as well. Before we begin, I would quickly brief about PlusPhysio. PlusPhysio is an AI-powered clinic management software designed specifically for physiotherapists. It simplifies day-to-day clinic operations by bringing appointment scheduling, patient management, documentation, and communication together in one platform. So yeah, PlusPhysio is an AI-powered clinic management software designed specially for physiotherapists. It simplifies day-to-day operations, bringing appointment scheduling, patient management, documentation, and communication together in a single platform. Today, PlusPhysio is supported by 965 clinics and has helped automation more than over 51,000 appointments, supporting 30 plus languages, and has reduced the patient's no-show by nearly 20%. Beyond technology, PlusPhysio is also building a strong community of over 1,000 healthcare professionals, also collaborated with academic institutions like Ganpat University and integrates with therapy devices to support better clinical outcomes. Our mission is very clear to help physiotherapists spend less time on administrative work and more of delivering quality care to the patients. It's my pleasure to introduce today's speaker, Dr. Shalin Shah. Dr. Shah is a leading pediatric orthopedic surgeon dedicated in improving children's bone and joint health. He's the founder of SOS Orthocare and a center focused on specializing pediatric orthopedic care. He has advanced fellowship training in pediatric orthopedics and has extensive expertise in managing cerebral palsy, developmental deformities, and complex orthopedic conditions in children. Dr. Shah is also highly experienced in clientele gait analysis, allowing him to accurately diagnose movement disorders and create personalized treatment plans. More importantly, he is known for his compassionate, family-centered approach that ensures every child receives comfortable and child-friendly care. Please join me welcoming Dr. Shalin Shah. Thank you so much. The stage is all yours, Doctor.
Yep, thank you. Let's see. Right. Are you able to see the full screen here?
Yes, we are able to see.
Right. The only thing I'm not able to see is your chat questions right now because I'm sharing it my entire screen. So the way
I'll be assisting you with that.
if there are questions, please stop me or assist.
Sure, I'll be assisting you with that.
Perfect. All right. So all right, good evening. Thank you for giving your 1 hour of your busy time here. As I was just saying earlier, the way I've tried to gather the talk today is my learning from my time here in India, in Canada. Currently, we are a group of super specialist orthopedic surgeons here in Ahmedabad, and each focused on one subspecialty in orthopedics. And my focus is pediatric orthopedics, with my training here in India, in Bombay, Ahmedabad, and then spending 2 years in Canada at SickKids and at Children's Hospital of Eastern Ontario. And my learning is gathered all around from world, from my time here as well as there. And it's been with time spent with pediatric orthopedic surgeons and pediatric physiotherapists alike, because sometimes the key in pediatric orthopedics is the diagnosis, and gait tells you a lot of things. And today I want to talk about some of the normal, the abnormal, and the gray zone of gaits. And I'm sure, just like me as physiotherapist, you see pediatric gait issues all the time. And there are some which need a little bit of nuance in how to treat them, and some which correct on their own and do not need us at all. And I'll try to make sure the line is clear among what's normal and what's abnormal. So I'll start with a story of a mother who came to me with her child who was 1.5 year old, 1.5 year old boy who had this bowing in his legs. So mom said, this my child has this bowed legs and that bothers me, so please do something for this. And I said, this is normal. And mom said, this is not normal because I have an older kid and the older kid does not have legs like this. And then she asked me to turn my head. I turned my head and I could see the older child who was 4 years old and had this bow legs which was going the other way. So the kid had knock knees. You can see the legs pointing to the outside. And so I retorted back to mom that now you turn your head to the left and you can see dad, and dad has straight legs. So this is the variation of how legs can be. They can be pointing inwards, bowing in. They can be knocked out, or they can be straight. And which of this is normal is a lot of confusion. Even orthopedic residents have, where I go and teach at Civil Hospital in Ahmedabad. And which of this is normal? And the answer is none of them. So what is normal is dependent on age, especially in children. So when we are born, everyone has bowed legs. So genu varum in the first 2 years of life is completely normal and physiological, does not need any treatment. And so is genu valgum. So from 0 to 2 years of age, you are born with genu varum, and then gradually that varus corrects as you age out. Around 2 years, the leg becomes straight, and then it goes outside. So it gradually becomes genu valgum. You get that valgum alignment, the peak of which is around 4 years of age, and then gradually it comes to the adult alignment, which is a little bit of 6 degree of mechanical axis or 6 degree of valgus. So if in infant age, what we do is cover up test, because if you cover up the tibia, which is where the most of the varus arises, and then if it's a straight leg, you do not need x-rays. If it's bowed after the cover up, which you can see here, then you see it's a positive test, and that might need x-rays and workup to rule out other metabolic conditions. So this is the picture I go to and share, which is a little knock is common in a toddler, a little bow in an infant is common, just like a little knock is common in a toddler. And it's just the legs finding the ground to their eventual straightness, which happens around 8 to 10 years of age. So I'll show you with a clinical example. So this kid at 1.8 years of age has this asymmetric varus. You can see the right side is a little bit of varus, but the most of the varus is on the left side. The mechanical axis is going all the way medial. But at 1.8 years of age, we know the Shalin curve, and at 1.8 years, it should be varus. So at this point, we just wait out. And then I followed this kid at 3 years, there's still varus. And what bothers me is this medial metaphyseal beaking, what we see, what we call as Blount's disease, which is why this kid needs follow-up. And for sure, on following this kid up, the varus remains. So at around 3.5 to 4 years of age, when most of the varus should have been corrected, the 4 years of age is when you have peak valgus, the kid still has varus coming from the proximal tibia, and that's when we go and treat these kids. And the treatment we provide surgically is we stop the growth on the lateral side, which allows the medial side to grow, and then gradually these alignment issues correct because of the tether which happens temporarily on the lateral side, what we call as growth modulation. Previously, braces have been tried, and they've known to be not working universally. For Blount's disease, especially for unilateral Blount's and bilateral Blount's, infantile Blount's, braces are given very commonly, and they're the first stage of treatment. But the real issue is compliance. In a toddler, in an infant, to wear these braces for 23 hours a day is very, very difficult for parents and for children as well. And we'll go back to this image which I show, and you can see the first thing we are talking about is bowing of legs and the knocking of the knees and them becoming eventually straight. But what follows is also the direction of the toes, and that's something which we all need to learn and remember as well. So this kid, he's 3 years old, has started walking, and then mom says, the way he walks bothers me. He does not walk normal. My older kid does not walk this way. I told her, you just don't remember, because the older kid, when he was 3 years of age, he walked the same way. And this is what we call in-toeing. In-toeing is very, very common. So in the infancy and toddler age group, everyone in-toes. That's because the way the femur are shaped. So because the orientation of the femoral head and the acetabulum, they have excessive internal rotation and less external rotation. They're more comfortable sitting in a W position and really struggle sitting in a cross leg position. These are the complaints parents come to us with. And all of these resolves by themselves. So the ligament of Bigelow right in front of the femoral head is a very strong ligament. And as you walk more and more, that ligament and the muscles, anterior muscles of the hip, they gradually push the femoral head to its eventual femoral version of adulthood, which is between 15 to 25 degrees. With what starts with around 45 degrees of anteversion goes down to about 15 to 25 in adulthood, and which is why they walk straight by that end. And the way you examine this is prone rotation. Hip rotations with the child supine gives you a hip rotation inflection, and that's not how we walk. The way we walk is with hips in extension, which is why the rotation of the hips in prone is very, very important. This video really shows it very, very well. You see, you rotate the hips with prone and you check internal and the external rotation. You can see this kid has excessive internal rotation. The internal rotation is almost 80 degrees, whereas the external rotation is only 45 degrees. So, which shows that this kid has femoral anteversion, and femoral anteversion is normal in infancy, in toddlerhood. By the age of 10, most of that anteversion goes away. So by the age of 10 years, your internal rotation is around 45 degrees, and your external rotation is also around 45 degrees. So your rotations become equal in and out by the age of 10 years of age. So if by the age of 10 years of age, your rotation at the hip, they are unequal, that means you have either a femoral anteversion or a femoral retroversion, and that may need treatment if there are issues with it. But otherwise, we just leave them be. Any focused exercise or not, any focused bracing or not, these kids are going to improve on their own. Forcing them to sit in cross-leg position, forcing them into a focused pigeon walk is not going to change the natural history. The natural history is going to change by themselves. It's the same story I tell. So I had newborn kids of myself, and our nanny came to me and told me, you should give physiotherapy. We do malish, so not physiotherapy. We do malish of children, and if you don't do malish, the bowing of the legs won't go away. And I have kids coming to me from all over India. We do malish of them, and their bowing goes away. And you come with this idea only because you only see children who have bowed legs, and if you're doing something to them, and then the bowing corrects. But the bowing is going to correct regardless of any form of intervention. So these are the normal conditions which do not need any intervention, and they are going to correct by themselves, which is why we need to know the natural history of these conditions. So femoral anteversion, it's normal in infancy and toddlerhood, and it corrects by the age of 8 to 10 years. The same goes for the coronal plane alignment. You're born with genu varum, you go on to have genu valgum, which peaks at 4 years of age, and by the age of 8 years, most of them come to the adult slight amount of mechanical valgus, which is the physiological valgus we all have. But sometimes some kids do need treatment. So this kid who had hereditary spastic paraparesis had such a big amount of intorsion. By the age of 9 years, you can see the left leg comes in front of the right leg. So this kid used to trip a lot. And that's when you do need treatment for intorsion. And you can see now after surgery, this kid, the left leg does not come in front of the right leg. And this kid has now stopped tripping. This is small intervention this kid needed was derotation of his left tibia, because and you could see when you put the kid prone, you rotated the hips, and both hips had some femoral anteversion, but that was not excessive. But what was excessive was the tibial intorsion, a combination of femoral anteversion and tibial intorsion, causing the child to trip every time that is pathological, and which is why we had to intervene. And similarly, if you have such a big amount of rotation, so this kid who has underlying diagnosis of arthrogryposis, and you can see the right leg has internal rotation issue, the left leg has external rotation issue, the right leg has extension contracture at the knee, and the left leg has a flexion contracture, and the kid is walking with a lot of difficulty. So these kids do need intervention, and do need intervention early on. And some of these are syndromic kids, some of these have neurological issues along with them. So we need to pick those up. So the first thing we need to know is what is normal, what a normal rotation at the hip, what a normal range at the hips and the knees. And then we need to know the natural history of them. And only then we can go and pick up all these abnormal gait issues. You can see, as I was saying, the left side, this kid is prone. So the left side has external rotation contracture. The right side has a little bit of internal rotation contracture. So that's all about normal. And we'll move on to a little bit of abnormalities of the gait. And this is one of the commonest issue we see in adolescent population, which is knock knee gait. You can see this is genu valgum alignment on both sides, and this kid is walking with the toes are pointing straight. She has turned an adolescent now, and what she has is femoral origin genu valgum. So we do x-rays of these kids. We do long leg standing x-rays, scanogram. We calculate the angles at the distal femur, the proximal tibia. We find out where the origin of this valgus is. But this is a gait issue, and if we leave these genu valgum as it is, in the long run, this will cause mechanical loading of the lateral aspect of the knee joint and cause eventual arthritis. So we do not want that abnormal loading to be happening on the knee joint, which is why these do need correction of the mechanical axis. What is something I do notice is some of them, just to hide their genu valgum, they would rotate their legs. If you have excessive genu valgum, if you rotate your legs internally and walk, you would hide some of that genu valgum. So you really need, when you're examining these kids, you really need to get the patella centered, and only then you'll get the correct alignment, coronal plane alignment. You can see the mechanical axis goes from the center of the femoral head, the center of the ankle joint, and it goes right out of the knee joint itself, which suggests it's a big amount of genu valgum for an adolescent age group. And the way we treat them again is we find out the origin, whether it's coming from the proximal tibia or the distal femur. Usually the varus comes from proximal tibia. Usually the distal femur is the origin of the valgus, which was the same in this case as well. And what we did was we intervened with a medial distal femur growth modulation, and we could get a decent correction of the mechanical axis. And you can see where the mechanical axis starts. It starts from all the way outside the knee joint, and with this simple intervention, they can get their mechanical axis corrected, improve their gait, and save their knee joint from a lot of mechanical wear, which can happen if it is left as is. Let's talk about some of the metabolic condition which children may present to. And you can see these two children, this is peak COVID time. You can see from the mask on their faces, this is peak COVID time. The children were being indoor a lot of time, and you can see this kid is walking with this waddling gait. He's trying an almost antalgic gait on both sides because there's so much pain he's feeling when he's trying to walk. And what this kid had was vitamin D deficiency. So vitamin D deficiency, as orthopedic surgeons, what we've commonly seen is in the infancy and toddler age group, and that presence as rickets. And you can see this on x-rays. You have blood investigations which confirm them, and we treat them with vitamin D supplementation and calcium. But adolescent age group, since COVID, this has been kind of a deluge of patients that we are seeing who have this antalgic gait after staying inside, not exposed to sun for a long time. And it started during COVID, and we are still seeing all of these patients, and they have this antalgic gait, waddling gait, and when we do their x-rays, they do show some sign of vitamin D deficiency, and the blood work shows that as well, and they improve a lot with just supplementation of the vitamin D. The other metabolic condition that we see a lot is scurvy. And what we see this specifically, I think a lot of neurophysiotherapists are there today, and they might be seeing this. So this scurvy is very, very classical of neurodivergent kids. So autism spectrum disorder, kids who have cerebral palsy with speech delay and other cognitive affection as well. They have this, and especially autism spectrum disorder kids. These kids, they have very typical eating habits, and they would prefer some things and not prefer to eat the other things. And if they have this bias towards not eating citrusy foods, then they develop this scurvy, and the presentation of scurvy is very, very interesting and atypical. So this kid presented with 15-day history, no history of fall, no fever, just refusal to walk. They had been to pediatricians and just not able to diagnose what's wrong. They got blood work and everything was just normal or borderline, which is why they were not able to find what was wrong. And the way, because it's bilateral, it suggests there's something metabolic going on. And we got x-rays, and you can see this white line of Frankel is what we call on the x-rays, which is very, very classical of scurvy. And that's what and then we got the blood work done, and it showed the vitamin C levels were very, very low. It was undetectable. We started the kid on vitamin C, and the kid started walking in a month, running around, came to a clinic. And you can see you can see this is the first presentation, and you see this hazy line around the physis, which gradually calcified after supplementation with vitamin C. You can see some calcification here as well. So what vitamin C is important for is formation of collagen, which is an important part of the physis, for the region from where the bone grows. It's also important for prevention of hemorrhages. So because there was vitamin C deficiency, the shadow here is sign of some hemorrhage which has happened around the physis, and then there is this calcification which has happened in that hemorrhage after vitamin C supplementation. So these are other metabolic issues you can see maybe commonly in some particular group of kids as well, and it's important to pick those up. So now I've talked about the normal variations of gait and how to just reassure parents and the children that all is okay. We have understood what metabolic conditions can do to gait. Now we'll go joint wise and look at what different conditions around each joint will cause an issue to the gait itself. So the hip joint, and this is something even pediatricians. So I work in an academic institute, in a teaching hospital, and one of the commonest referral I get is, this kid has pain in the hip, so please rule out DDH. And that is really not true, because DDH itself, until the age of 10 or 12 years, it's really a painless condition. You can see this kid, she has a short limb gait. She's 5 years of age, but just walking normally. And if you get her x-rays, you can see the hip is all the way out. So that's what DDH is. It's a missed dislocation of the hip. Breech, birth history, female, first child, all of these are risk factors for hip dislocations, and they might be walking abnormally, with a short limb gait, which is why measuring limb length is very, very important. Getting an x-ray before treating abnormalities in gait in children is as important as well. And DDH is really a painless condition, which is why it gets missed all the time, and which is why we see walking age DDH kids and not detected early on, because it's very difficult to pick them up clinically world over, and that's something which is coming into India as well. There is universal screening programs, screen every child's hips with ultrasound, so we can find kids who have hip dysplasia early on. The only issue is the incidence of DDH is 1 in 1,000. So completely dislocated hips, the incidence is 1 in 1,000. So you have to do ultrasound of the hips in 1,000 kids to find one abnormal hip, which is where the real cost of this investigation comes in. Same way, this kid has bilateral hip dislocations and walks so normally without pain. It's not a normal walk. You can see while walking, the child sways the pelvis. So this is again a waddling gait. The pelvis goes to and fro on both sides. This is because the abductor lever arm, the lever arm of the hip joint is really insufficient, which is why the kid is, instead of using the abductor muscles, the kid is swaying the torso and the pelvis side to side. You can see the exaggerated lumbar lordosis, so which is another sign of bilateral DDH, especially bilateral hip dysplasias will have this exaggerated lumbar lordosis as they try to compensate for bilateral hip dislocation and bilateral insufficient hip abductor musculature. So painless hip conditions may get missed, and which is why we need to pick them up. Sometimes it's the asymmetry of the abduction range which will help pick them up. Sometimes it's the limb length discrepancy, but the really difficult ones are the bilateral hip dislocations, which is where identifying a gait issue, identifying waddling gait, identifying that lumbar lordosis really helps. Then talk about painful conditions. So this kid has antalgic gait on the right side, and you can see the amount of stance phase on the right lower limb is reduced. And this kid on examination had reduced internal rotation, reduced abduction, and the X-ray shows this kid has Perthes. You can see the calcification or there's more whitening of the epiphysis on the right side, which suggests this kid has Perthes disease, which is avascular necrosis of the hip. Again, initially it will be painless. Sometimes there will be inflammatory flare up, which is where they will have complaint of pain, and which is where they may present at some stages. But otherwise, Perthes itself also is a painless limb. You'll just see this insufficiency of the abductor lever arm on one side. Again, this kid, again during COVID, you can see she presented with an antalgic gait, and she was really progressed, which is why she's walking in such a manner. You can see the toes are pointing to the front on the right side, whereas on the left side, the toes are pointing on the front on the left side of the kid, as the right leg goes all the way out. And when we examine this kid on the bed as well, every flexion of the hip went all the way out. And what this kid had was skiffy. So skiffy is a condition we see around 8 to 10 after 10 years of age in adolescence for children, where there is a physial slip. And this is something which really get missed, because there's common nerve supply of the hip and the knee joint, which is something every one of us should know. So a lot of these kids present with knee pain. Sometimes they have seen an orthopedic surgeon, and what they've gotten is a knee X-ray. But which is why examination of the hip joint when you have knee pain is very important. And this kid who had knee pain ongoing since the past 1 year had knee X-rays and was told everything is normal. So he was just biding time, and gradually his gait got really worse by the time he reached us. And when we got an X-ray, you can see the hip is pointing all the way out. It's almost 90-degree rotated all the way to the outside. So it's a chronic slipped capital femoral epiphysis, and the hip is pointing, the femur is pointing this way, the hip joint is pointing this way. There's a 90-degree disorientation in the way they are pointing towards each other. So which is why examining knee joint when there's hip pain and hip joint when there's knee pain is very important, especially the hip joint, because a lot of them present with knee pain or abnormality, just diffuse pain around the knee which is unexplained. The other thing I really want to talk about today is FAI syndrome. Some of you might have heard about this. It's femoroacetabular impingement. It's a triad of hip pain, limited hip range of motion, and abnormal mechanical contact. It's a condition we see in growing adolescents and around adulthood. As the physis fuses, the way it fuses and the way its closure happens, sometimes it forms an extra bone around the femoral head. Sometimes it's associated with muscle tightness as well, which is why any kid with hip pain should get an evaluation of all their muscles around the hip and knee, and all the muscles which cross the hip joint itself. So we do an Ober's test for iliotibial band tightness. We do a Duncan-Elliott test to make sure there is no rectus femoris tightness. We do a hamstring stretch test, which is the popliteal test, and then we do a FADR, which is flexion, adduction, and internal rotation, to find out if there is significant impingement there. And all of these tests are important in their own way. It gives us the idea of which muscle is tight, whether there is any active impingement or not, along with an X-ray. So if there is focused muscle tightness, the very focused physiotherapy to relieve that muscle tightness would really help many of these kids. I would say 70 to 80% of children and adolescents who have femoroacetabular impingement, they improve with just a focused physiotherapy regime. and those are the ones who do not improve. After that, we need to do surgical intervention for their femoroacetabular impingement. You can see this 18-year-old female has this abnormal bony contact, and you can see very clearly on this frog-leg lateral view, there is, instead of your circular spherical femoral head, you can see this continuity of the neck with the femoral head. So there's extra bone formation here, and we check that by measuring of the alpha angle and the head neck offset. And usually the offset should be 10 to 15 millimeter. And you can see there's almost no offset here between the head and the neck, which suggests there's, every time the hip flexes and internally rotate, this part impinges with the acetabulum here, which is where they get bony contact and which is where they get on labral tears. In the treatment for labral tear, the first treatment is still physiotherapy, because sometimes if the muscles get strong enough, the labral tear will stop being symptomatic. But if after all interventions of physiotherapy and focused strengthening of the muscles, if it does not work, we do go in surgically with an arthroscope. We do go ahead and repair the labrum and do an osteochondroplasty, so this does not happen again under the guidance of CM.
Dr. Shalin,
Mhm.
there are a couple of questions. If you
Yes.
can address, or we'll be addressing it at the end.
No, I think we can address it right now because it might be a lot to take all the way together. So it gives
Yeah.
a
So
good break to everyone. Yes.
yeah. So there is a question in the Q&A session.
Mhm.
S. Nirmala has posted a question. I need to know about the opinion of using baby walker will change the gait pattern in a normal kid.
So baby walker, the way we prescribe this is, the only point we do not want to give walker is we don't want to give it very, very early. So baby walkers are okay as long as it's around the right age for a child. So we need to remember the appropriate milestones. So routine milestones for children is they have head holding around 3 months, they have start independent sitting around 6 months of age, they start cruise walking around 10 to 12 months of age, and after 12 months they start independent walking. So once they start cruise walking around 10 to 12 months of age, if a baby walker is given, it's all fine. The only issue is when parents start to have a race for these milestones. This kid, I have this kid in my neighborhoods who started walking at 8 months of age, and I want my child to start walking early as well, and that's where issues start cropping up. If you give a walker at 8 months, it puts a lot of pressure on the bony physis as well. In fact, I would go ahead and say that some of the earlier genu varum that we see are in kids who were made to start walking very, very early. So if you're starting to use baby walkers at 7 months or 8 months of age, those are the population where we see earlier onset of genu varum. So baby walkers are okay as long as the right age is used for them. Does that answer your
Okay.
question, Nimila?
Yeah. So till that time, we have another question from Dr. Avni.
Uh-huh.
Uh, at the age of 9 year, is it normal to have genu varum in child?
No, it's not. So genu varum, the normal age is up to 2 years of age. Sometimes in kids who have had rickets and it had not been corrected and it was only picked up around 2 years of age, we give vitamin D supplementation and then we wait up to 1 year for it to correct by itself. But by 9 years of age, if there is genu varum, there is an abnormality. These are the kids who should have an evaluation with an X-ray. And usually around this age, the most common diagnosis is Blount's disease or adolescent tibia vara.
Okay. I hope it answers the question from Dr. Avni.
Hello, doctor. Can I ask a question?
Yeah, please go ahead.
Nirmala, pediatric physiotherapist. As you said that giving normal for a normal kid, it is okay to use a walker, baby walker. But in tackling pediatric physical therapy, it is that giving walker, baby walker for a normal kid itself is not indicated. So it changed the pelvic obliquity. And what's your opinion as a orthopedic surgeon?
as an orthopedic surgeon, I don't prescribe it, but there are a lot of enthusiastic parents who come to us, who are excited about getting their child walking, and with pelvic obliquity, the what my understanding and what our understanding as pediatric orthopedic surgeon for hip dysplasia is in is I would not say congenital condition, but it is something you have from your birth, and a lot of it is how your hips were placed intrauterine. So hip dysplasias and the pelvic obliquity associated with hip dysplasia, most of that comes from the way the intrauterine position of the hips, how they were placed. We have not seen any evidence of how how the use of walker would lead to a physical obliquity in the pelvis itself.
I don't think so. Actually, in normal kit itself, you should never, as a therapist, you should never recommend. In the textbook, it was written like that. For an abnormal, like if a CP child you are treating, no, if they are asking baby walker, you can use for that. So, what is the answer as a therapist? I should address the parents, and such question was raised.
Yeah, the answer is for us it's no harm as long as it's at the right age. We do not prescribe baby walkers. I don't say everyone should use a baby walker, but if any parent is very excited, I don't think it causes any harm to pelvic obliquity after 10 months of age, as long as it's the right age for walking.
And another question, doctor.
Mhm.
W sitting is normal. I had a suggestion from my junior's colleague child, 1.5 years, and he usually have the habit of W sitting. And her mother is asking whether it is normal or it is abnormal.
It's absolutely normal. So W sitting is not a habit. The way I explain it to parents is, the way the femoral head sits in the acetabulum. I explain to them in this way. How did you get from your house to the hospital? Most of them use either an Uber or an auto rickshaw, or they drive in their own car. And the reason they do not walk to the hospital is because it's comfortable in a car, it's comfortable in Uber, or it's comfortable in a rickshaw. That's the same for a child. The child is sitting in a W position because he's comfortable that way. The shape of the femur and the shape of the acetabulum is such that the most comfortable position for that hip is when the child sits in a W position. It is not out of habit. It's a physical limitation that he cannot sit in a cross-leg position. So, I had my nephew who was sitting in this W position. I explained to my sister that this is normal, and I explained that this is normal at 3 years of age, at 4 years of age, at 5 years of age, and every time she was very very worried. And at 8 years, he grew out of it, and children grew out of it because as you walk more and more, the shape of the femur changes, and the femoral anteversion gradually reduces. So if a child is sitting in this W position a lot, what I would like you guys to do is, make the child prone and then rotate the hips. And if you see this physical excessive internal rotation and less external rotation, then that gives you a reason. The way the femur is shaped right now is there is excessive internal rotation and less external rotation. See the kid at every 6 months and 1 year, and you'll see gradually the internal rotation reduces, the external rotation improves, and when it becomes equal, the child will be able, once it's more than 45 degrees, once the child has more than 45-50 degrees of external rotation, he or she will be able to sit in W position very very comfortably. Our intervention for W sitting are not going to change the natural history. Forcing a child to sit in cross leg, forcing a child to not sit in W position is not going to change the natural history. The natural history itself will allow the child to sit in a cross leg position as the femoral head shape changes.
Thank you, doctor.
Can I ask one question, Dr. Shah?
Yes, yes, please.
Dr. Shah, I have a rehab center and my child is cerebral palsy diplegia who is coming to my clinic since from 5 years. He was having totally hyper tonicity in both the knees bilaterally, and it was like a fixed flexion deformity in both the knees. Now I'm treating since from 5 years, and now from last year there is no hypertonicity in both the knees. There's no flexion deformity also, and he can walk now independently. But when he came to me, he was 6 year old. Now he is 10 year old. So he is walking like a duck walking.
Duck as in he walks with his knee flexed?
Yes, but there is no tone now. The tone has been reduced, but still the walking pattern, I'm not able to, correct that gait.
Yeah, the reason for crouch. So, I guess from my understanding, if the knees are flexed when he's walking, but the knees can get
Yes, yes.
straight when he's supine. So the reason for crouch are, there are a lot of reasons for crouch. The most common is, hamstring tightness, and hamstring tightness. If you have a very tight
But there is
hamstring,
now no hamstring
yeah,
tightness
So,
also.
so the
That also
commonest
is reduced.
the commonest reason is hamstring tightness. But once the hamstring tightness has been treated, either surgically or with good physiotherapy and focus, sometimes Botox injection, that goes away. They have lever arm dysfunction as well. So sometimes they have
But
plain
Botox,
valve.
he has taken too many Botox injections,
Yeah,
but that
no, no,
has not
yeah,
released.
yeah, which is why now his hamstrings are loose enough, but still he's going into crouch. So the reason can be a lever arm dysfunction. If he has plano-valgoid foot, that lever arm dysfunction can
Yes,
lead
yes,
to a
that is.
crouch gait as well. If he has, soleal insufficiency, if he has weak gastrosoleus complex, that can lead to crouch as well. So there are multiple reasons for crouch. Just tight hamstring itself is not the only reason. Weak quadriceps can be a reason for crouch as well. You need to get your knee completely straight. And if your quadriceps are insufficient to get that knee straight, then you can get crouch as well. So sometimes you need to, push that in with ground reaction AFO. What a ground reaction AFO does is, if there's soleus weakness, the soleus usually is needed to get the tibia straight for during the ankle rocker of the gait. And if it is weak, you need the ground reaction AFO to push the tibia posteriorly, get the knee straight. So if after all your good stretching, good
So with
Botox,
this GRFO, the crouch gait will also be corrected. The crouch position of the hip
some of
will
them.
also
So if
be.
it's only
Okay.
soleal insufficiency, then ground reaction AFO is enough. If it is more than that, if there is patella alta, then the knee extension mechanism is at fault as well. Then those kids will need, patella tendon plication. They would need surgery. If there is plano-valgoid foot, then it's a lever arm dysfunction. Then that plano-valgoid foot would need correction. Sometimes if the plano-valgoid foot is flexible, the ground reaction AFO corrects the plano-valgoid foot along with the soleal insufficiency. So the first, get them evaluated by a pediatric orthopedic surgeon or a good P&O, someone who does good orthosis. And if fitting in an orthosis corrects most of his gait, that might be enough.
The second question is, one more child is there. He has an intoing of gait. Like one leg is in hyperextension of the knee and one leg is in intoing. He's coming to me when he was 8 months old. He's a cerebral palsy quadriplegic. Now he's into independent walking, that, but I'm not able to correct that intoing of a right leg. And hyperextension, while walking, he hyperextends the left leg and right leg goes into internal. So
Yeah, so cerebral palsy is a big spectrum, and spasticity is not the only problem in cerebral palsy. Sometimes they have hypotonia, and hypotonia is one of the most difficult thing to correct. If you have high,
but this child was hyper. He was not hypo. He was a
yeah,
hyper quadriplegic.
yeah, but he does go into, recurvatum is what it goes into hyperextension now.
Yes, yes.
Yeah, so
It, like you can say sometimes the tone was, it is like a right arm was in a hyper and the left leg was in hypo and the left arm was in hypo and the right knee was in hyper. It was a
the
cross
way
type of.
the way you're describing it sounds more like dystonia. So if it's altered tone, if there's dystonia,
Yes,
those are
altered tone. Yes.
so they are the most difficult to treat, because even with medicine, sometimes if you have high tone, you can treat them with medicines, sometimes with Botox, and you can treat the tone. But dystonia, it's the origin of dystonia is different from the origin of spasticity in the brain itself, and those are the most difficult ones to treat because they are not the same tone at all points. So and the other thing is intoing. So intoing in a normal kid in a non-neurodivergent. So kid who does not have any neurological issues, in towing is normal until 6, 7, 8 years of age, because as they walk more and more, it corrects. But autism
But he's
spectrum
now
kids,
10-year-old.
kids with cerebral palsy, kids with autism spectrum disorder, they do not walk normally. They walk less and less, and which is why their muscles are not strong enough to push the femoral head back, which is why their intorsion, sometimes femoral anteversion does not correct by itself, and which is why sometimes these would need surgery to correct that femoral anteversion. And
But
rotational
in
issue.
CP cases, if intervention is done, you mean that it will not come again? It will be corrected once, so it is.
Yes. So the which is why the intervention should happen at the right time. After the reason, so cerebral palsy is a non-progressive condition. It is an insult which happens to the brain around perinatally, and then it does not progress at all. But because the reason we see progression as they grow is because it focuses on the neuromuscular junction. So muscles which cross more than one joints, they are the ones which are most affected. So gastrocnemius crosses knee joint as well as the ankle joint. The rectus femoris crosses the hip joint as well as the knee joint, which is why these are the muscles which are more affected. And so these are the targeted muscles. And as you have growth spurts, every time there's a growth spurt, you will see tightness in those muscles because the muscles fail to catch up the growth which happens in the bone. So if we treat muscles, if we treat at 6 years of age, you give Botox, it's great, and then around 9 years they have a growth spurt and it becomes tight again. And that's their natural history as well, because as every time a growth spurt happens, you will have recurrence, which is why if we treat around 12 or 13 years of age, you won't have any recurrence because there's no growth spurt left. The second reason for recurrence is every time we treat muscles, we induce a weakness, either with Botox or surgery. If we lengthen a muscle tendon junction, you're inducing weakness there. Whereas for rotational issues, we are treating the bone, we are not treating the muscle. And bone is one of the only tissue in the body which forms new bone. So if you injure a muscle, it will form fibrosis, where if you injure a bone, it will form new bone. So it's one of the only tissue which has the capacity to regenerate. So which is why for rotational issues, we cut the bone and derotate it, new bone forms, and in a few months, it's back to where it was. So if surgical treatment is done at the right age, you do not see recurrence, especially for rotational issues. Rotational issues in cerebral palsy is one of the most under-treated condition, I would say, here as well as around the world, because it's not really picked up very easily, and rotational issues would cause a lot of gait issues as well. So those should be picked up and treated appropriately.
Thank you so much. Thank you so
No
much.
problem.
Yeah, so there are
Bhavini has raised hands twice, and then I'll go through the chat questions and maybe I can answer them. 3-year-old with Klinefelter syndrome, genetic disorder, walking supported with excessive abduction.
Hello.
Yes.
Hello.
Yes,
Ah,
Bhavini, please.
Yes. Sir, my question is one of my child, he has a condition, hemiparesis, since birth. Now he is a 4.5 year, and he is sitting like W sitting. And what happened? He's totally normal now. Walking is improve. But what happened? Therapy gap 3 to 4 days. So what happened? Tightness is only present. No improvement at all. So what is the reason? He's like sitting like W sitting. It's bothering. So
W
I
sitting.
can't find.
No, as I said, W sitting is very normal up until almost 10 years of age. So some kids, they improve by 4, some improve by 6, and most of them improve by 8 to 10 years of age. So up until 10 years, we do not treat W sitting at all. Even in neurodivergent kids, they do not need treatment, because as they walk more, they will correct by themselves. If it's a hemiplegic kid, most of that is going to correct. But what we all know is diplegic as well as monoplegic or hemiplegic kids, all of these kids should have a hip x-ray, a pelvis AP x-ray
Mm-hmm.
at 2 years of age, 4 years of age, 6 years of age, 10 years of age, because a lot of them will have hip migration. So DDH is something which happens intrauterine and the hip dislocates. But a lot of cerebral palsy kids, because they have this fetal excessive anteversion and they do not walk as much as a non-neurodivergent kids walks. So the femoral anteversion remains as is, which is why the acetabular coverage remains deficient, and some of them they go on to dislocate. So Pediatric Orthopedic Society of India has come up with this hip screening program in cerebral palsy, and it has this big chart of when X-rays, pelvis X-ray should be done in diplegic kids and in hemiplegic kids, and
Okay.
and these screening is very very important. So if you are seeing some rotational issue in a kid with especially in spastic kids, and
Mm-hmm.
sometimes in non-spastic kids,
Yes,
you
he is
would
a
see him.
non-plastic
Yeah, yeah,
hemiparesis is
yeah.
there.
Yeah, even in those kids you would see hip dislocation. So if you're seeing issues in the hip, but do get an X-ray,
Mm-hmm.
it might
And
help pick something which is missed as well. But W sitting is completely normal, does not need
okay.
focus treatment at this point.
And I find also LLD.
Yeah, so
So,
limb line discrepancy is a
huh,
concern. So if they have, a hip which is migrating outside,
okay,
should get an X-ray and make sure the hip is okay. Some of these
okay,
kids might have hip dislocations.
okay. Thank you.
Any kind of metabolic issues other than rickets or vitamin deficiency that causes Genu varum? A lot of them. So not even classic vitamin D or rickets, even hypophosphatemic rickets. All of these might cause Genu varum. Genu varum, one of the commoner cause other than rickets is TB is Blount's. So Blount's can have unilateral or bilateral affection and would lead to Genu varum. So X-ray for sure in a kid who post 2 years of age still has persistent Genu varum. 9-year-old having genu recurvatum while standing and flat foot hip muscles are weak, it will be corrected with exercise. This 9-year-old or any treatment required. So genu recurvatum, flat foot, all of these are pointers for a kid who has generalized hypermobility. So if you examine this child, do a Byton score, she will have get the thumb to touch the volar aspect of the forearm. Pinky toe will have more than 90 degree of extension. These kids, and they will have hyperextension at the knee, which is what I think you're trying to tell with genu recurvatum. So these kids, they have hyperlaxity, and this is part of this generalized hypermobility syndrome. What the observation of pediatric orthopedic surgeons is these kids, they do excellent in gymnastics, they do excellent in dancing, and sometimes they fall back a little bit in sports. And to get them stronger, obviously good exercise and physiotherapy would help, but otherwise it's a benign condition, does not need anything else, does not need any intervention for mild hyperextension at the knee or flat foot. And I had a talk, if we had gone further on, we could have talked about flat foot. So flexible flat foot, it's very important to differentiate flexible flat foot from a rigid flat foot in pediatric population. Flexible flat foot, you get your toe up if the arches appear. If a non-weight bearing, the arch appears, does not need treatment at all, does not need sole, does not need focused exercise of the arches. Flat foot is normal and common in pediatric age group. In toddlers, in infants, flat foot is completely normal, and as they grow gradually their arches appear. And flexible flat foot does not need treatment. Earlier, there used to be this rule that or at least this dogma that the army does not take people who have flat foot. It's completely untrue. Flat foot is not pathologic. Flat foot does not need flexible flat foot does not need treatment. But what what is important to understand is the differentiation between flexible and rigid flat foot. 6-year-old got stroke, 3 years, not due to proper physio. Hip angle got changed, associated scoliosis. This angle will correct with proper physio. If the kid has scoliosis, if the kid has hip issues, should get an X-ray first. If there is physical limitation in the hip abduction, there's something structurally abnormal with the hip, needs to correct it first before intervening with physio. Network issues. Yeah, 9 years normal having Genova. No, it's not normal. Needs a X-ray and possibly an intervention. Extremely dystonic quadriplegic CP child with complete support should how often should visit for joint evaluation. Quadriplegic CP at least once a year. The physiotherapist is the primary care provider for these kids, but should visit a pediatric orthopedic surgeon once a year. One to evaluate tone, whether they need any change in their bone health, if they need any supplementation, and get an X-ray of the pelvis. And we do this follow up until they are skeletally mature.
Good evening, Shah, sir. Good
So
evening, sir.
yes.
Yes, sir. Sir, I just would like to ask you one question, sir. Actually, I have a toe walker who is of 4 years old. He is taking the treatment since 1 year. He is able to walk with the normal feet after taking the treatment, sir. But he is unable to stand in a normal posture. Like he is flexing his hips while standing, but while walking, he is able to walk properly.
So, and you're saying this kid has he's idiopathic toe walker. Every neurological condition has been ruled out by a pediatrician or a pediatric neurologist.
Yes, sir.
Yeah, because in my book, an idiopathic toe walker is someone who has had a thorough neurological evaluation. Every neurological condition has been ruled out. Toe walking, the way I treat them is I treat them very aggressively early on, focus physiotherapy, stretch the gastrosoleus complex, stretch the tender Achilles as much as you can. And
Yes, sir.
even early on, if it's bothering, we would treat them with serial casting as well. So, how old did you say this kid is?
He is 4 years old, sir.
4 years old. So, what we see until as they gait starts to develop from 1.5 years of age when they start independent walking, and it takes up until 4 years of age for normal gait to develop. Earlier on, hip flexor tightness is normal, and gradually as they walk, the hip flexor stretch out, because earlier on, if as they're crawling more, as they're sitting more, the hip flexors and the anterior hip capsule is usually tighter. In kids with idiopathic toe walkers, sometimes trying to get the sagittal balance correctly, getting the center of gravity correct, sometimes they would tilt the pelvis anteriorly as so as to balance their idiopathic toes, so as to balance their as they're standing on their toes, they would try to get the pelvis in front. So obviously evaluate the hip, but hip issues in idiopathic toe walker would not be pathological usually. So treat only the toe walking itself. Good physiotherapy, aggressive physiotherapy, and if needed, serial casting to stretch the tender Achilles out. And if they don't, correct by this group of intervention by the age of 9-10 years of age, then surgical intervention at that point.
Actually, while he is walking on a rough surface, he is able to walk properly, sir. He is able to stand properly on a rough surface, but on a flat surface, like on the tiles or on a mosaic, on a smooth surfaces, he is unable to stand or
Is
walk properly.
is he neurodivergent? Is he autism spectrum or anything else as well?
He comes under autism spectrum,
So
like
so
he's hyperactive.
Yeah, so the thing we know about autism spectrum disorder is their sensation, their perception of the floor is very different from what a normal kid would have the sensation. So the way they feel surfaces is different, which is what explains what you're trying to say. On some surfaces he's able to stand flat, and some surfaces he's not able to, and the reason. The primary reason could be that the child has autism spectrum, and the perception of the floor is different for them. And some get them used to a single surface, maybe get them used to walking with boots on almost all surfaces, and treat the toe walking in that way. But there's nothing pathologic about that. It's quite common that we see autism spectrum kids perceiving the surfaces differently and walking in different ways on different surfaces. Gradually, as they get used to those surfaces, they will walk with their feet flat.
Okay, sir, but giving him some kind of footwear which have some type of bubbling
type of footwear will be helpful for him?
Yes, get a good orthosis. Then it's really trial and error for kids who are neurodivergent, because what might work for one kid might not work for the other. So make try different things and make sure he's comfortable with whatever he's feeling, and the different types of footwear would work for a kid. So make sure obviously the tender Achilles is not tight, and after you stretch it out, if he's going into this toe walking on certain surfaces, try different kind of orthoses or shoe insert and see what works for them.
Okay, sir. Thank you so much.
No problem.
In case of left handing, we can put a cast for use that right hand properly. Like it left hand muscle, child is left handed. Hello, good evening, sir. Can you hear me?
Yes.
Case of left handed, the child is not using that right left hand. So we can put cast and right hand. Like CIM.
I'm sorry, the voice is breaking, or I don't know, Himanshi. Could you get the question? And I can maybe answer.
No, there's some network issue. Her voice is breaking actually.
Okay.
Okay. Can you hear me now?
Yes,
Yeah,
but
we
it's
are
still
able
breaking.
to hear you. Yeah.
Maybe you can type the question and send in, and I'll be happy to answer. I think Trupti has a question. If a baby milestone is delayed, baby already having cerebral palsy, scissoring gait on observation, what should be the protocol? Any kid with cerebral palsy, classify GMFCS level. So gross motor function classification system, classify them whether GMFC is 1, 2, 3, 4, 5, 6. And what is globally recognized is once you classify them GMFCS wise, they stay on the same stage, and your focus is they do not fall. You do not want a GMFCS 4 kid, GMFCS 1 kid to become a 2. You do not want a GMFCS 3 to become a 4. A 3 is an ambulator with support, and a 4 is a non-ambulator. So you do not want an ambulator to become a non-ambulator. So that is the first concept we should have in mind. The next thing is scissoring gait. So all of these are individual affections. Scissoring happens at the hip, crouch happens at the knee. And tight tendocles would lead to sometimes toe walking or planovalgus feet, all of these different affections. So you look at the ankle, look at the knee, look at the hip, what is happening at each of these joints. But one of the first focus should be on truncal strength. So first focus, the physiotherapy protocol, I guess for sure you guys were the physiotherapist here would know better than me. But for cerebral palsy is, get them in a stender, get them to stand using stender every day for about 30 minutes, 45 minutes. What that helps is keeps their bone health good, so they do not fracture through them. The next is have a good stretching protocol, and the third is focus on high kneeling. The first thing a cerebral palsy kid should have is good truncal strength. So focus on high kneeling so that they can stand on their knees and without any support, because that's the first thing I see before doing any intervention. A kid can have tight hamstring, tight tender Achilles, but if the child is not walking and does not have truncal strength, I would not intervene in them, because it is of no use. Getting completely correcting the knee flexion contracture and a ankle contracture would not get the child walking if the child does not have truncal strength. So the first protocol should be get them good truncal strength, and then we can focus on stretching out the hamstrings and the tender Achilles. Child with left hemiplegia, is cast helpful to put in right hand? Yes. So what, Pratna, the question I think you're asking is about constraint therapy, and constraint therapy is universally recognized and is one of the most successful therapies for kids who have hemiplegias. So cast on the opposite hand would get the child to use the affected hand, and sometimes especially after stretch casting. So if I have thumb in palm, I have this pronation contracture, stretch out the thumb, stretch out the pronation contracture with either a cast under GA, or if it's an older compliant kid, a cast in supination for 10 or 15 days, maybe with a Botox, and then remove the cast and put the cast on the opposite arm. So the child is forced to use the affected arm, and that really helps. So constraint therapy is really helpful in kids with hemiplegia. 3.5 years of age, post vaccination, hemiparesis in right arm and left leg. Right hand is functioning well, but there is flat foot and foot is abduction and external rotation. There is also hip hiking on the same leg. History of hydronephrosis. Sounds like a syndromic kid. I would stay away from, recommendation before I've seen this kid, because seems like a lot is going on. And post vaccination, neurological issues are known, especially in, if especially after measles vaccination. So a good evaluation first before suggestion of anything. Hallux valgus along with hip rotation deficit in children with gait abnormalities. Is there a biomechanical relation between these findings? These are usually independent. Hallux valgus bunions, they do have an association with flat feet. So flat feet and hallux valgus bunion is very, very common and they have association. But foot issues in adulthood, you can see foot issues can lead to hip issues or hip pain. But in pediatric population, biomechanically, a foot issue would not cause any rotational issues in the hip itself. It does cause a biomechanical disadvantage. A flat foot would cause a planovalgoid foot would cause a biomechanical disadvantage, but would not affect the hip joint itself. Post-operative protocol for crouch, I think it needs a very focused lecture for itself. Cerebral palsy, I had a couple of early smaller slides, but I think it would need a very focused talk on it. But yes, there are post-operative physiotherapy protocols. Maybe I'll share a PDF with Himanshi and she can share it afterwards. But they have this dip initially and then they progress. 6-year-old case of hemiparesis due to tumor excision of severe flat foot. He is keeping his elbow flexed and wrist is flaccid. Tendoculus is too tight and waddling gait. Is this Botox and then release? 6-year-old, we usually start with Botox and stretching, and sometimes only if it's very, very severe, then we would do a soft tissue procedure at this age. Post-tumor excision, especially a brain tumor, would cause, the flat foot itself would need a specific focused evaluation before I would recommend any intervention. Spinal fusion, 13-year age, elbow, wrist, knee, ankle, reduced joint space with reduced joint spaces, developed at 4 to 5 years of age. Sounds like a syndromic kid. Sometimes, epiphyseal dysplasia present like this. Sometimes pseudorheumatoid dysplasia presents like this. So this kid would need an evaluation before I can recommend anything. 3-year-old Klinefelter syndrome, genetic disorder, walking supported with excessive abduction, limb length difference of an inch. Are there chances of hip dislocation? Yes. A lot of syndromes have associated hip dysplasia. So if you're seeing a limb length discrepancy, get a pelvis X-ray would really help finding if there's any associated hip dysplasia. Sorry, Manshi, I think I did your work as well.
Yeah, but I hope that the questions that we have answered have covered and also resolved the doubts that the attendees have. So that was the major agenda.
I think Bharti is trying to speak, but she's on mute.
Yeah, so I hope mostly all the questions are covered till now.
Yes.
And also we are running out of time.
I think we ran out of time already. I had a lot of more slides to share, but maybe some other day and some other time. But thank you.
Definitely.
Thank you for your time. All right.
No worries. If required, we definitely will be scheduling another session for the further more content that we have to share.
Yeah, no problem. All right. Thank you.
Definitely. Yeah, thank you. Thank you so much. It was actually insightful. We being non-medico people have also learned a lot of things. But yes, definitely it was an insightful session, and I hope all the questions that the attendees have listed are properly answered and resolved.